So before we start with the practical part of this book and review surgery and the planning of surgery, let's start at the very basic process. Let's review how we reach our decisions. How do we decide to operate or not to operate? As neurosurgeons, we are trained to make fast and hard decisions. So look at this MRI scan. Is this a surgical case? Yes or no? You have 10 seconds to decide. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Your vote, please. So obviously, as a neurosurgeon, you cannot go for undecided. You don't know, perhaps uncertain, not sure. The right answer, of course, is that you cannot give an answer. You have insufficient data to judge whether this lesion is surgical or not surgical. You don't know the patient, you have just seen the MRI scan, and you have just assumptions. Sorry that I might have pulled your chain a little bit, but that is exactly what happens very often. We just see an MRI scan and then we rush up to the OR without getting all the information that we need for a thorough decision-making process. So decision-making in neuro-oncology, as in many other disciplines, is a multifactorial process. This process is basically an integrational process of multiple aspects of the disease. We usually start with an MRI scan and assumption of a diagnosis, in this case probably glioblastoma. That means it's an infiltrating brain tumor. So infiltrating brain tumor means that there's probably no cure for the patient. However, there is probably a big impact on the survival of the patient by surgery, as demonstrated here by this Kaplan-Meier curve from Walter Stummer paper. On the other hand, we have to be aware of the natural course of the disease. For example, as demonstrated here in the Mandonnet paper, the growth curve of the tumor might be benign for decades, and we don't need to put the patient at risk at that moment. And maybe most importantly, we need to understand the social situation of the patient. Is it apparent? Does the patient have family support, or does he have to support the family? And in cases of elective surgery, like in low grades, is it a good time for him to have surgery now? Is he just at the point to embark in a career? And would brain tumor surgery at that point destroy that? And can we postpone that surgery? By the way, speaking about career, it's also important for you to do brain tumor surgery. And maybe your career is influenced by the number of cases that you're doing. And maybe this is a demanding case and you want to show off. And therefore, your career triggers also the indication for surgery. Now, after this consideration of soft skills, let's go back to bare physics. Very important step now, and we will review that in another video in this book, is the analysis of the risks that the patient is at. What is the location of the tumor? Is it very near to eloquent structures? Are there vascular risks? In most cases, it's sufficient to sit down with the normal MRI scans that you have usually at your hands and review this MRI scan with the knowledge of your anatomy. We will show that in another video. Another important detail in planning the surgery is the potential use of adjuncts like 5-LA and the preparation for that technically. And then, of course, you can plan the monitoring. You need to specify for you and your team and for the patient what kind of monitoring are you going to perform. Is it awake? Is it asleep? Do you need SSCPs, MEPs? Will there be cortical stimulation with monopolar 60 Hz stimulation, subcortical stimulation? What are the systems at risk and how to prepare the patient for that? And of course, you will find a dedicated session on this planning in the next videos. At that point of your planning, you're probably able to estimate the extent of the resection that you can perform. Is it just a biopsy? Is it a lesionectomy? Is it a supramarginal resection? Can it be at some parts also a subpile resection? Planning the surgery is also planning for adverse events. What happens if the tumor is partially functional? Will you still go on, or is the idea that you need to preserve the functions at all costs? What happens if you, during surgery, have to realize that you have interfered with the internal capsula by closing lenticulostriatal arteries, and the patient will be most likely pelagic? Will you go on with surgery? Will you abort surgery? For most infiltrating brain tumors, surgery is just the start of the treatment. And of course, as a doctor who takes care of the patient, you need to be aware of what is going on after surgery. You need to plan that and involve that potential of adjuvant therapy into your surgical planning as well. So what is going on in your mind when you're planning surgery is that you have to balance multiple factors and integrate them in a decision-making process, which at the end is digital, yes or no. Finding the indication for surgery of an infiltrating brain tumor is a very complicated process and might be more complicated, more time-consuming than the surgery itself. In fact, it's not unusual that you sit down with the patient and the relatives of the patient and discuss the surgery over and over again until every question is cleared, and that is what our patients deserve from us. Thank you very much for your attention, and looking forward to see you later.